You've been in ophthalmology for 30, 40 years now, and you've been in the forefront of ophthalmology's evolution over the years. And what do you see in ophthalmology in terms of glaucoma that's striking and innovative for ophthalmologists to look at?
Actually, I started my residency in 1973, so this is 40 years now. And when I was in my training, we were trained to do a Shea thermal sclerostomy as the surgical treatment of choice, and the drops we had were primarily just pilocarpine and epinephrine. So the changes are enormous, and they're both in the surgical field and in the medical field. So maybe I should talk about surgery first and then a little bit about medical changes. The biggest breakthrough really earlier in my career was the development of trabeculectomy and then the tube shunts, and they're very effective treatments, but they have a very high complication rate. And so we get good low pressures in the 13 millimeter range in the tube versus trab study with both procedures, but at the expense of a very high complication rate. And what we really needed was a safer, less invasive procedure. And we now have several procedures in the category that I call minimally invasive glaucoma surgery. Some call it microinvasive glaucoma surgery. The first one approved that I think fits in that category is the Glaukos eye stent. And we're using that actively in our practice and finding it, very effective. And the nice thing is that the complication rate is basically zero. It does lower the pressure more than just cataract surgery alone, and it's approved mainly for use with cataract surgery. But it's the first in a category, and there are many to follow. We have Transcend, we have Aquasys, we have Ivantis, and a group of companies that are investing heavily in making glaucoma surgery safer. So what I think the patient of the future has to look forward to is a safer but still effective operation, and I think that's going to be a wonderful advance. On the pharmaceutical side, the advances have been equally spectacular. Our first great breakthrough drug was Timoptic or Timolol, and it's now off patent and generic. And then we had the prostaglandin drugs, including to start with Xalatan, that's now available generically as latanoprost. And those drugs really revolutionized our treatment. They were, again, much more effective with less side effects than the pilocarpine epinephrines. So our medical therapy has advanced tremendously as well, and on top of that, carbonic anhydrase inhibitors and the alpha adrenergics. So we now have a much more powerful pharmaceutical regimen than we did 15, 20 to 30 years ago, and we also have a much safer surgical armamentarium, and so great advances for glaucoma.
What do you in your crystal ball, what do you see us going in the area of glaucoma?
The biggest problem we have in glaucoma actually is timely diagnosis, and the major issue that we face is that about 50% of people, even in an advanced country like the United States, that have glaucoma don't know it. And so we are pretty effective at treating now, particularly if we diagnose the disease early, but we need to diagnose the disease better and more frequently at an earlier stage. So I see a lot of the advances being in diagnostics and advanced screening of patients so that we can diagnose the patient. And also there's a lot of patient education to do to let patients know that they need to be seeing an eye doctor, certainly at least every couple of years when they get to age 40, and have someone check their pressure, look at their optic nerve, and basically make the diagnosis, because today, if we make the diagnosis early, we can usually prevent progressive damage.
Do you have any words of wisdom for ophthalmologists when it comes to compliance?
Well, a real big issue with any chronic medical regimen, whether you have hypertension or glaucoma, for example, is being able to sustain the regimen for decade after decade. And in ophthalmology, what we've learned is the compliance is somewhat proportional to the number of drops that you have to take, and somewhat proportional actually to the amount of patient education that's done. And so we're getting more combination drops where patients can be on a single bottle once a day regimen. That's going to help significantly, and I think we're getting better abilities to educate patients so they really understand the disease and how important it is to treat. And then as we get more minimally invasive procedures, I think more and more patients who have difficulty with compliance, we'll be much more comfortable offering them a surgical option. So the future will be more once-a-day regimens, a better education, and then a quick transition to a safe surgery if the patient has difficulty following the regimen.